It's so good to see each other here. Thank you for this great experience. We have 15 minutes, so I'll just go through our experience. Many patients we have helped and also helped them to relieve from the tumor. And this is just 2 cases that probably we talked. And then we go through the stories as a slide, okay? And then we can discuss further what is cancer vaccination, how to induce fever. This fever and hyperthermia, our positive experience is fever is a secret and missing link to this relapse-free complete remission. Not just complete remission, but you can actually induce the remission and relapse-free. This is very possible. Case 1 is actually changed, 39 years old. We start to see very young cancer patients nowadays. Everybody just check their spike protein. It's very important. We start to see cancer patients as they, this less than 40 years old. That's a problem. And then diagnosed with breast cancer, mass to liver, typical story. That's December, about 2 years ago, after the lockdown. So biopsy done is a double positive, and then typically there's a chemo go through. Then PET scan shows it's okay, and then there's liver cyst, fibroid. Then started, of course, the tamoxifen, the usual, one size fits all thing. And then there's June, and then there's local recurrence again. So that's from June, and then 1 year later, less than 1 year, the recurrence is the problem. Then there is this tumor on the left breast, and then you can see is a PET scan in this area here, and the patient is really anxious. And this is in June, okay. And then you can see now after the treatment, this is October, June to October, the tumor is disappeared. Okay, and you can see before, and then this is after. Okay, so the treatment timeline is actually from the June. What we did, actually hyperthermia was initially 3 times a week, and then later we go into the Amiram protocol more intensive. There's mesothelioma therapy as well, and then intratumoral injection of bicarb ozone. Because the tumor is so surface, right? You can do intratumoral injection and induce the cancer local regional cancer vaccination group. You can do ICV, immune checkpoint inhibitor, gemcitabine, and then GM-CSF, Fraxini, this mixed bacterial fever. This is a Coley's vaccination program, Coley's fever. So about 7 sessions, then ICV, 5% only we use, we don't do high dose. This medium to low dose. This low dose ICV is actually a protocol by Dr. Ralph Cleave, who's a very famous Vienna doctor, okay? Then Coley's fever, and then LDIPT, this is low dose IPT, DCA 17, and this IDC. Then in August, this is an August treatment as well, much the same, okay? And then we added on curcumin and then selenium, right? And then intratumoral injection because the tumor is so surface, okay? And then hyperthermia more intensive in the September to October. So from June to October, that's very good targeting. This is a PET scan report on the June 14 to October 13. And this is the SUV 4.46, and the previous completely resolved. Okay, so patient very happy, and then the doctor also from the PET scan center also surprised, and also is wonderful. So those are quite a simple case, and also a recurrence is typically is a failed conventional, then recurrence, then patient do not want any more chemo or radio surgery. Although it's operable, but the patient doesn't prefer that. The patient wants to go. I guess leaving the patients with option is very important. Second case is this madam, 61-year-old lady, and then pancreatic carcinoma, and then we can see this housewife, cholecystectomy done. Actually on a wheelchair when they presented to us, she was so sick. Okay, then in the history was 2019 February, abdominal bloater, then March, gastric problem, then May, pancreas mass is 4.5, and then at that time normal CA199. Then June, 2/3 of the pancreas resected. This is a Whipple procedure. It's very hard to treat the patient. Usually when they go through this conventional method, surgery, chemo, okay, typical. Then the disease progressed actually in 2020. So 2019 sick, and then 2020 disease progressed, recurrence. Typically the relapse come back less than 1 year, right? Then this June to December, second round of chemo done, second round, okay? And then recovery year, stable disease, and then CA199 is still 49 that time. Then January 2022, January, new finding metastasis to bone this time. Then she started the third round of the hospital, CyberKnife, oral chemo, lymphoma. January, cancer marker keep rising to about 13,000 when they presented to us in March, I think this year. 13,735. Okay. So then what happened was that we do the usual hyperthermia remission. Then duration was from April to July, 57 days of we do treatment closer, and then abdomen upper and lower. Total completion is about 45 hours, and then average about 60 minutes per day. Sometimes 2 sessions, sometimes 1 session, 5 days per week. 5 day rest 2 days. And then we also do local regional, face down, sometimes right lateral position sometimes. So integrative oncology treatment therapeutics are the whole human management. We teach the person to manage the human survive, and then colon detox, and then hydrotherapy, diet, liquid nutrition, and then intensive resuscitation to the patient. All right. Then immunity revival, unleashing the white blood cell using ICB, stimulate the T cell responses. It's very important. Just manage the human. Number 2 is manage the immune system, stimulate it, not to reject it. And then feverish whole body hyperthermia. Okay, just now we saw some Hector machines. Yes, we do that for the general whole body fever. And then we use Coli's fever for the patient. So the solid tumor disturbances, intervention, disruption, disturbance, and then destroy or dismantling the tumor local regionally, even the abdomen is very important. So, and then liquid tumor and solid tumor vaccination. So this patient actually, the pancreatic mass was 5.8, liver lesion 1.9. Okay, and then comparison, the patients do very well. Okay, and then you can see the before. This is the before and after. This is before. Yeah, this is after. Okay, before, this is after, right? And then this is the before. This is very small already. Okay, the SUV, the pancreas is a local recurrence. Usually NK cell will increase. Okay, if you really check the NK cell, there's the extra benefit, which is not to say is international data, but local data, yes, there is. So OB is normal, OB became normal, even the bleeding in the stool became normal. Then you can see March and then August, okay, there's cancer marker 13,000 to 686. So this is a serial, but sadly to say the patient passed away later because of this, went to hospital for this lung fluid drainage, over drainage, or somehow just, we lost her. But so we have good success, and also we have lost patient also because due to other things. So let's discuss how do cancer patients die. Usually because of cancer complication leads to mortality. Usually overly harsh treatment, too harsh for them. Keep on changing the drug after 2, 3, 4, 5 times. Why don't we do something also integrated and also outside the box? Okay, so usually cancer patients die of overly harsh treatment, starvation, space occupying lesion is occupying the space. So we also can discuss stage 9 cancer because a lot of patients are stuck with this, what we call cancer cell trapped inside the host body. Immune system trapped and suppressed, not unleashed. Okay, and then the white blood cell is not, everyone knows that the patient has cancer, but one guy don't know, the patient's white blood cell doesn't know the cancer. So we are supposed to train the patient's immune system to see the cancer very obviously in the patient. So then heavy metal toxicity, severe HO toxin hindrance for any possible healing. Sometimes the patient is so impossible into the healing conditions because of this famine, severe chronic nutritional deprivation. This is what we call stage 9. There are actually more stages of things. There are more than meets the eye and what I want to say. So how do we do? Immune system destroy or increase the treatment? Sometimes increase the treatment. Between the treatment and the immune system, which one? Treat too much and immune system is destroyed. Between the cancer and the patient, kill too much of the cancer, patient died. Or we save the patient or kill the cancer, or help the cancer and kill the patient. Which one? So we have to reach the solution. So this is important. So for us to understand, very importantly, is keep the patient alive. The patient's survival skill is important. So it takes more than the dietitian, nutritionist, food therapist, and physiotherapy to do a integrative program rather than just doctors and running from hospital to home, hospital to home, hospital to home, hospital to suddenly hospice, hospital to hospice. No, that's not the right way. I think we should be able to, why should we palliate the patient first before we offer them the cure? why should hyperthermia be the number 5th options? Okay, if all else fail, then hyperthermia works. Why can't we do hyperthermia early? So just now the exercise there, we talk about what are the 3 things that you learned today. Okay, number 1, hyperthermia works. Okay, number 2, it will stimulate immunity. Okay, number 3 things that I learned, hyperthermia should be done much earlier. Much earlier, and in combination, that's wonderful. Give options to the patient and family is important. Okay, then immunity is very important from the T cells. If the innate stimulate the T cells, talk to the B cells for cross-talking, have a retention memory, that's very important. Our immune system is an organ in the whole body. Therefore, the treatment must be the whole body management, whole body approach rather than just local regionally. So in situ tumor vaccination for the treatment of cancer, this is a paper by 2016. Stimulate an immune response in situ at the tumor site. Exploit the potentially numerous tumor-associated antigen. Every tumor has a TAA, tumor-associated antigen. It's effective in situ vaccination when you do intratumoral intervention or local regional hyperthermia. Okay, the concept of in situ vaccination is actually to exploit the TAA or TSA, tumor-specific antigen. The 80-20 rules. The 80% is good cells, 20% is antigen inside the tumor. So these 80-20 rules, a lot of people don't understand, but then we should talk about this. So here's the slide just now that I'm glad somebody talked about that also. Release of cancer antigen, okay, antigen presentation to the dendritic cell, then priming and activation of the APC and T cell. So the APC antigen present, talk to the B cell and go to the lymph node. Then train the whole body, recruit the whole body, then trafficking of T cells to tumor. Yes, hyperthermia can deliver the activated T cells to the tumor. Yes, and then the T cell migrate into the tumor. Yes, when you do hyperthermia, blood flow improve. Then recognition of cancer cell by T cell. When you do low dose radiation, became obvious. And then when you continue to disrupt, then of course you help. Then killing of cancer cells. Yes, that's number 7. So 1, 2, 3, 4, 5, 6, 7. So we can even bypass the activation of the cross-talking. A lot of people think the T cell talk to B cell, you can only use the conventional way. But there's this STING pathway and also immunogenic cell death. We are trying to do immunogenic cell death rather than the tolerogenic cell death. So we have to expand the neoantigen repertoire, inhibit the the Treg, kill some Tregs together. So cyclophosphamide can help the Treg to kill off. Okay, this is a slide talking about the worse, the more malignant is the tumor, the more neoantigen load that they have. If you expose the antigen, it can become a very strong stimulant, immune stimulant. So the art of exposing cancers from occult into an obvious is to do disruption, disturbance, okay, destroy or dismantling the tumor organization, macro and micro tumor environment. So targeted therapy and immunotherapy absolutely wonderful, important. So the ICV, low dose ipilimumab, nivolumab, pembrolizumab, bevacizumab is very helpful. So this is a slide talking about tolerogenic and tolerogenic cell death and immunogenic cell death. Often we focus on high dose, maximum tolerable dose versus the slow and medium, moderately adaptive dose. I think the adaptive dose is wonderful because we want the green pie to increase. Tumor rejecting immunity is lifelong. Retention of memory. The T will go and eat and then present to the B. The innate talk to the adaptive, and then cross-talking. The cross-talking can be really armed up by this MBF. They call it the mixed bacterial fever, the William Bradley Coley. Okay, so this is the slide talking about tolerogenic cell death and tolerogenic cell death, which is what we do not want that macrophages do. We want to the left side here, macrophage. This is what we call immunogenic cell death. So spontaneous remission is often happen with this 1962 William Coley, surgeon who cut tumors, discovered Coley's toxin, which is actually the fake bacteria. Also, this William Bradley Coley, the father of immunotherapy, Dr. William Bradley Coley, who's doing surgery, he understands that if you do surgery, you repair the tumor. You have to train the body to repair the cells because the repair can go into repair the foreign and then the pathogen will increase. And then train the immune system to kill the tumor, repair system to go and repair the cell. That's very important. So this is so Coley's vaccine also is intratumoral injection. This is actually the fever. We use 3 methods to improve fevers, hyperthermia, whole body range, natural exogenous fever, rising the temperature a few times. And then we can do endogenous fever induction by COVID vaccination. So we are actually wanting to talk to the world COVID vaccine practitioner. If you are out there, I would like to be connected to you. If any one of you know about this COVID practitioner, basically in Mexico they have. If you want to do, I would like to be connected to them. Keep an eye. So intratumoral injection is this improve this tumor vaccination. So remember the innate, okay, and then the T cells to the B cells, very important. So don't forget the circulating tumor cells in the blood. How do you know it's embryonic cancer stem cell? You can check the cancer stem cell. This is a non-Oxford SOX2 that is under this embryonic cancer stem cell present in the blood and the lymphatic system that you can actually detect them and then do a vaccine. So there are 7 methods to wrap up. Okay, detoxification always important. Gut microbiome, full spectrum nutrition, oxygenation, ozone, oxidative therapy, immunomodulation, stimulation, non-toxic cancer therapy, more than 27 types of plants, right? And then spiritual and emotional healing, very important. Okay, this is on the left side. Okay, 80-20 rules. A human is a body suffer with a cancer syndrome with a tumor which is 20%. There's a soul and the spirit from the left move to the right. That's very important. Okay, this is bring the patient to the right side, which is spiritual and soul is very important, which is 5 to 20, the 10 to 20, 30 years of survival skill is here. The tumor actually 20% is the toxic one. Okay, remember artesunate, vitamin B17, DCA, selenium, Imucotel. I think Imucotel and selenium are very famous in Korea. And then curcumin, fever, and then this hyperthermia. Wonderful. So with this I conclude, and then if you have questions, thank you for listening. Okay. All right.